Dear friends and colleagues, welcome everyone to the EuroPCR e-course roundtable discussion on transcatheter PASCAL repair system for the treatment of mitral regurgitation. My name is Philipp Lurz from University of Leipzig, and with me are two world experts in the field, Holger Nef, University of Gießen, and Scott Lim from University of Virginia, US. This is a summary of what we put together, a comprehensive program about the PASCAL system. We will start off with a discussion of what we and all of us should maybe consider as an acceptable and what we should consider as a perfect result when performing transcatheter repair of mitral regurgitation. We will then go into the evidence for this system from the clinical trial setting, but also the real world evidence with the PASCAL repair system. And then we will have a deeper dive into how this procedure is actually performed. This includes a case presentation and then also a recorded case. So the three of us, we are all involved in the clinical trials on this system. This includes the PASCAL study, the ID study, and then also the PASCAL 2D and 2F trials, and then some registries. What can you expect from this session? You will hear new clinical data, 12-month data, which will be also released as a late-breaking clinical trial presentation within the EuroPCR e-course, and then also a very new and latest analysis of the PASCAL commercial experience with more than 1,200 cases, and then one case example or a couple of case examples, and also a recorded case which should illustrate how this procedure is performed. We will start off with the first talk and a discussion on what should be achieved when performing these procedures.
Hello, Philip. Hello, Scott. Thank you very much for this introduction. And it's my privilege to give you a short overview about the importance of achieving mitral regurgitation 0 to 1 plus for patient outcomes. I hope that I can cover all aspects within this short time, and let me go through quickly. Well, as we all know, we have, I think, a robust body of evidence that the outcome of patient after mitral valve repair is directly correlated with the residual MR. And you can see in this very recent study that patient with an MR3 plus or MR4 plus are doing worse in the long-term run in comparison to patient with residual MR2 plus. And we have extensively discussed the results from the COAPT and the MITRA-FR trial. And one special aspect is that patients in the MITRA-FR trial show more moderate to severe mitral regurgitation at discharge, which might have a direct effect on the results or different results we have seen. So I think it's clear that we should achieve at least a residual MR grade 2 plus, but the question remains, can we do better? And is an optimal, which means a mild or less residual MR 1 plus or less, is better than an MR 2 plus? Well, there are some doubts. If you look at the early studies, this is a registry coming from Cologne, and as you can see in this image, there was no differences between a residual MR grade 1 plus or 2 plus in these small registry. However, we have this confirmed by the latest results from the COAPT trial. As you can see here, there was, although there was a numerical tendency, but there was overall no statistical difference between the cohorts with residual MR 1 plus and 2 plus at discharge. So we have to look at opposite registry, which is one of them is the Swiss registry, and you can see the sign, a small sign that maybe a better result like an MR1+ could lead to a better outcome in these patients. And this is confirmed again by newer registry. And if you look at the TVT registry, you can see nicely that there is a difference if patients are discharged with a residual MR of 1 in comparison to the residual MR 2+. And if you do a multivariate model for 1-year mortality, you can see that the residual MR is a clear predictor for a good outcome in our patients. If you look at the registry coming from Germany, and this is a mixed cohort of FMR patients and DMR patients, you can see in the overall cohort that there is a difference between the 2+ cohort and the 1+ cohort. And even if you look separately to the DMR or FMR cohort, this difference sustained. So if we go now to the latest results coming from a registry in Hamburg, you can see that also in total or in only FMR patients, these results could confirm. And if you look at patients with a residual MR 1+, they had the best outcome in comparison to MR 2+ or more. And I think most importantly is the fact that an MR 1+, which sustained over 1 year, had the best outcome in patients in comparison to patient. They had an MR 1+ at discharge, but they have a worsening of their residual MR to 2+, which was clearly inferior to patients which sustained in the MR 1+. So let me conclude. I think we have growing body of evidence from single and multi-center studies which showed improved outcomes for patients with a residual MR 1+ at procedure or discharge. And I think there is a clear relevance of this optimal result, which should sustain at 12 months. And the recent data show that it impacts also long-term outcome of our patients. And I conclude that every implanter should aspire to achieve MR 1+ in every procedure for long-term benefit of their patients. Thank you.
Holger, I think that was an excellent talk. I think you're really showing us data that supports what many of our surgical colleagues have been arguing for some time, that particularly when going after mitral valve disease, we want to have the absolute best results possible. From some of our early data, we thought just 2+ alone was good enough, but I think more and more, as you've shown, there's a real need to try and get the results to 1+ or less.
Yeah, you're completely right.
Can I maybe ask the two of you, when you discuss these patients in the heart team, do you include considerations about what to achieve in a specific patient and set expectations before and think about whether your aim in this anatomy should be an MR grade 1 or 2, depending on how challenging the case is? Is it something you adopted already in your decision making?
You know, at my institution, we do. We have a discussion between surgeons and cardiologists and try and sort out if we think we can only get the mitral regurgitation down to 2+, so not an optimal result of 0 to 1, that is it worth in that given patient, leaving that patient with residual of moderate residual MR? And if the answer is no, then we choose a different strategy for that patient.
So it seems like that the definition of an optimal result shifted already in our clinical routine from 2+ to 1+, but the question remains on how to achieve that in all of our patients. And then maybe we continue with looking at the evidence for the PASCAL repair system in clinical trials and presented by you, Scott.
Good afternoon. So I will be discussing both the PASCAL device and delivery system, as well as the most recent data from the Clasp study on it. My disclosures are as listed here. The PASCAL device has a number of differentiating features, including a central spacer, broad curved paddles and surfaces, and the ability to independently capture the leaflets. The delivery system is catheter-based, with a 22 French guide sheath, a steerable catheter, and an implant catheter. The device was designed to achieve the goal of mild 1+ or less residual MR by utilizing a central spacer, the independent leaflet capture mechanism that allows optimization of the leaflet insertion, and elongation of the device to allow positioning and repositioning with less risk of chordal entrapment. The spacer concept of PASCAL was designed to fill the regurgitant orifice without needing to pull the leaflets together as tightly, thereby decreasing stress on the leaflets. And as you can see on the right-hand panel, there remains an acute angle to the paddles, leaflets, and clasps, but the spacer remains where the regurgitant orifice was. The leaflets are able to be captured either by bilateral actuation of the clasps or, in complex cases, by staged leaflet capture. In either case, optimization of the leaflet capture is frequently done with a mechanism to optimize how the leaflets lie between the paddles and clasps. And the leaflet retention elements are in a horizontal orientation at a position designed to target the midpoint of the leaflets to engage the retention elements with the stronger collagen fibers of the section of leaflet. Thus, the goal is optimizing firm capture of the leaflets while minimizing tissue damage. So we embarked on an initial investigation of the PASCAL device in the Clasp study. This was a single-arm, multi-centered prospective study evaluating safety, performance, and clinical outcome in patients with significant mitral regurgitation. Note that the key inclusion criteria for Clasp included both degenerative and functional etiologies of mitral regurgitation. The primary study endpoint for safety was major adverse events at 30 days, and for performance was a composite of device, procedural, and clinical success. It was an international study with sites here in the EU, in North America, and Australia. Over 100 patients have been enrolled, and I'll be presenting the data on the 54 that have made it to 1-year follow-up. The study demographics on the entire cohort of 109 patients is shown here, with 2/3 having functional and the remainder degenerative etiologies of mitral regurgitation. 100% of them were adjudicated by the independent echo core laboratory to have 3 or 4+ MR. 95% of them had a successful implant with a mean of 1.4 devices implanted and a procedure time of just over 120 minutes. 94% of implanted patients were then discharged home following a short hospital length of stay, albeit with some regional variation. Major adverse events at 30 days in 1 year were relatively low. There was one case of SLDA, single leaflet device attachment, that occurred acutely, and the team was able to successfully convert it to a surgical valve replacement. In this cohort to 1 year, there was a 92% survival and 88% freedom from recurrent heart failure hospitalization following the PASCAL implant. The MR reduction was impressive in this cohort, in which 100% had either 3 or 4+ MR at baseline as adjudicated by the Echo Core Lab, and the panel on the right shows that the data on those that have follow-up echoes out to a year, with 100% having 2+ or less residual MR and 82% having 1+ or less MR, with nearly a fifth having no residual MR. The transmitral gradients post-PASCAL device remain low and stable at 4 millimeters mercury mean out to a year. And as expected, the patients had significantly improved functional class that was sustained out to a year as well. Functional assessment by Kansas City Cardiomyopathy Questionnaire scores demonstrated significant improvement that also was sustained out to a year. So we concluded that the Clasp study, noting that the unique PASCAL device was safe and performed as intended. The initial outcomes were favorable and sustained results to a year with very robust reduction in MR, and in a fifth of cases, elimination of MR. These compelling initial results have led us to the randomized Class 2D F trials, which are demonstrated here. These essentially are two separate trials, with those patients with primary MR etiologies in Clasp 2D and randomized against MitraClip, and those with secondary MR etiologies in 2F, and also randomized against MitraClip after determination of failure of optimal guideline-directed medical therapy. Both trials have echo core labs and eligibility committees adjudicating enrollment and outcomes. Thank you.
So thank you very much, Scott, for this very important demonstration and summary of the evidence for the PASCAL repair system. And we move on, shifting from the controlled setting in the clinical trial to the real world and the evidence we have so far from commercial cases. Now, the PASCAL repair system entered the real world, and I would like to give you a brief summary of the latest evidence from this real world experience and what we have learned so far from an analysis of 1,200 patients. So what we've certainly have seen that this device performs in a variety of anatomies and morphologies. This includes functional mitral regurgitation, which was the majority majority of cases in 56%. There were also some patients who were treated with degenerative mitral regurgitation, and then some patients with mixed lesions. Now, importantly and very positively, the safety signal from this real-world experience so far has been excellent. Freedom from intraprocedural death or conversion to surgery was 99.8%. Again, very few serious adverse events, in total 1.7%, out of which about 1% of cases were single leaflet device attachment, meaning that the device came off of one leaflet, but this appeared to include a certain learning curve as well, with less SLDA cases within the last 200 cases performed. From safety to efficacy, reduction down to MR grade 2 plus or less in 79%, but we want to achieve even better. As you've just heard, the percentage of patients with an MR grade of mild or less, 73% in this experience. There were some technical non-success cases where the procedure had to be abandoned in 4.6%. So as always with these procedures, patient selection is key, and there is certainly an ongoing learning with regards to that. The procedure time median about 1 hour, which is very reasonable for a procedure like that, and the average number implanted per patient was 1.3, meaning that there were more patients with only one device, but equally in a significant portion of patients, 2 devices were implanted to achieve that MR grade 1 or even less. And so it's not necessarily always a one device procedure. Here you can see the results stratified according to the etiology of mitral regurgitation, with the best results for functional mitral regurgitation, 77% of patients with an MR grade of 1 or less, and then a little bit fewer cases with these excellent outcomes in those with mixed lesions, as to be expected, because these procedures are normally a little bit more complex given the more challenging anatomy. Now, it is important to understand that, as always with these procedures, there is a certain learning curve to that. In the top row, you see the percentage of MR grade 1 or less according to the etiology, and then also stratified according to the number of cases performed at the individual centers. And you can see that this improves quite early during the experience. So after 25 cases, better results at the individual centers. The same is the case for the procedure time, which also came down, was a little bit higher in the first 5 cases, and then rapidly came down after 25 cases performed. So there is a learning curve, but this is not too long. Now, a few last words about our own experience here at Heart Center Leipzig. We've done more than 50 cases, and here you can see the distribution of the procedure time for these 50 cases, which came down, but then also the number of devices implanted. We started off with considering this procedure to be more as a one device procedure, but if you want to achieve an optimal result with an MR grade of 1 or less, then it can often be achieved by implanting 2 devices. This can be done safely from a procedural point of view, and in the vast majority of cases with acceptable gradients. As seen in the trials and in the real-world experience, again, almost 80% with an optimal result at discharge, but then also at 1 month. So this appears to be well maintained, at least in the short-term follow-up, and that had also functional implications with an improvement in walking tests and walking distance in these patients. So in conclusion, the PASCAL demonstrates safety in a real-world experience with an excellent safety profile, very low serious adverse events, and rates of single leaflet device attachment. There's a high rate of MR reduction down to grade 1 or less, and this can be achieved after a short learning curve. About 80% of patients will have an MR grade of 1 or less after the procedures, when that with a procedure time of less than 60 minutes after a certain learning curve.
Philipp, I'd like to congratulate you. That's very impressive data you just presented, essentially real-world experience. One of the pieces of it that is particularly striking is the learning curve. That procedure times that you presented, essentially about an hour, is essentially half the amount of time it was in the early clinical trials, where it was people's first couple of cases with it. And do you think that's something that also can be taught, and new sites coming on to any sort of transcatheter repair can learn that as well with this particular device?
I definitely think so. I mean, when you do the very first cases, even with perfect proctoring and teaching, it will take a little bit longer. But the experience we had has been repeated by other centers from communication, what I've heard, that there is a learning curve, but the procedure time will come down very quickly. And in our experience, it was about after 10 patients. So, which I think is a fair number of procedures.
Great. Shall we go on to the next part, the case presentations now?
Okay, thanks, Philip. This is my case review. I just report from an 80-year-old man with coronary vascular diseases, having a non-ST elevation myocardial infarction on 2014 with the following PCI. There are a variety of comorbidities, which includes chronic kidney disease, COPD, sleep apnea, and there is a medical history of gastrectomy. Just to step into the TOE pictures, that is the four-chamber U, and you can see this very eccentric regurgitation, which I think is due to the fact that we have this flail of the anterior leaflet due to a cord rupture, and the result is this eccentric, very posterior, in the posterior direction of the regurgitation jet. This is in the commissural view. Also, you can imagine that there is an A2 flail, which leads to this severe mitral regurgitation. Just to have the 3D view showing nicely the flail with the ruptured cords here in the A2 scallop, leading to the severe mitral regurgitation. So after the transeptal puncture, we are already here in the clocking situation, and so we look for directly the positioning of the PASCAL device in an A2 position. Of course, we have this auto hugging situation, and we have to go a little bit more in a flex position with the guiding catheter, just to have this more anterior trajectory. After having done that, so we are ready to grasp the leaflets. First of all, we want to be sure that we are at the apex of the pedals, as Scott mentioned already before, and that we are directly also in the regurgitation chat. And this is the grasping situation, and we can see that the anterior leaflet as well as the posterior leaflet are nicely tightened after closing the PASCAL device. This is the results. This is the result after closing the PASCAL device, which shows a nice reduction of the MR to a residual MR 1+. Just having a short view on the 3D color Doppler, just confirming the reduction of MR to this the optimal result. The pressure gradient is in 2 millimeters of mercury in mean, so that I think overall we can see that there was an optimal result in this patient with a DMR. Thank you.
So I'm going to present this case mainly because it has both an intermediate term follow-up of 2 years and that it illustrates some important points about the PASCAL device. The patient had been sent to me from the head of our heart failure team, who had been following this patient for a number of years with a non-ischemic cardiomyopathy. But unfortunately, this patient more recently had a number of recurrent heart failure hospitalizations in the few months previous and really was struggling a fair bit, despite being on as much guideline-directed heart failure medications as his blood pressure would tolerate. The mechanism of the mitral regurgitation was a Carpentier type 3B due to tethering of the posterior leaflet. The mitral valve orifice area was 4.2 centimeters squared by 3D planimetry with a mitral inflow gradient of 4 millimeters mercury mean, despite a significant amount of MR with an EROA of 0.4. So this was a small valve with a lot of MR. And in my experience, if we were doing a mitral clip, we'd only have room for probably one clip. And with that much MR, may have significant residual MR. The patient enrolled in the original Clasp study and underwent implantation of the PASCAL device, which is shown here. The device is highly visible by 3D and by 2D echocardiography. With the device grasping both leaflets and being closed, I think the fluoroscopy, as shown on the right, demonstrates 2 important points. Even in its closed position, the paddles and clasps remain at an acute angle, which is not as tight as a mitral clip would be, and therefore indicative of less stress on the leaflets. And number 2, that the PASCAL device flexes with the cardiac cycle, opening up slightly more in diastole and closing down slightly more in systole. Both of these points together, I think, equates to a greater residual diastolic orifice, which is particularly important in small mitral valve orifice area patients. While there was substantial improvement in MR after only one PASCAL device, we felt that it was important to place another device to further reduce it to mild or less, as a mean inflow gradient had not increased. And with the second PASCAL device, we had virtually eliminated the mitral regurgitation. And the mitral inflow gradient was a mean of 3. The left atrial pressure had substantially fallen with the elimination of the large V waves, and the cardiac output significantly increased. We left the case feeling like we had achieved a remarkable success for this patient. And now, at a follow-up of 2 years after the index PASCAL procedure, the patient has had no further heart failure hospitalizations, and he has become and remains relatively asymptomatic. The mean inflow gradient remained low at 3 millimeters mercury, and by the echo core lab, there was no residual MR. Thank you.
So congratulations to both of you for really 2 excellent procedures with a fantastic outcome. I have 2 quick questions for the both of you. Scott, I'll start with you. You showed that in a not terribly large anatomy, you were able to implant 2 devices and get that great result. And you alluded to the point that this can be achieved with again, acceptable gradients. Could you repeat again, what's the theory? Why can we achieve low gradients despite the fact that we implant two devices of considerable size?
Yes, so these PASCAL devices, while they're of considerable size, they are flexible. They're made out of a nitinol and essentially a mesh of that. So with your hand, you can actually squeeze them. As a result, when they're implanted on the mitral anatomy, they tend to flex, open and close a little bit. And therefore, in diastole, they flex open, allowing larger residual orifice areas. And in systole, as the forces from the ventricle are transmitted up through the mitral valve leaflets, it flexes closed. So I think you're getting the best of both worlds of a residual orifice in diastole as well as better MR reduction.
So this is very important and a fundamental difference as compared to the mitral clip. And then Holger, again, excellent result. In an anatomy like that, what's your first approach? Simultaneous grasping or independent straits?
Well, it depends. Like if you have seen, so after correction of the trajectory, so there was a perfectly laying of the leaflets on the clasp, so or the pedals. So we had also no curling of the leaflets. So in this situation, of course, you can grasp directly both leaflets. However, if you have some kind of problem, I tend to go first with the anterior leaflet and then go to the posterior side and grasp independently, which might also in this situation beneficial in comparison to the mitral clip devices. So. However, in this situation, there was a good trajectory of the clasp, and we could successfully grasp both leaflets directly.
So more options and the ability to optimize with staged grasping.
Absolutely.
So now we'd like to show a case presentation in much greater detail how this device is used to achieve optimal results. Philip.
Thank you, Scott. So the patient we approached for this procedure was a patient with a preserved left ventricular ejection fraction with severe mitral regurgitation, as you can see here. That's the 3D anatomy with a localized focal coaptation defect at the center of the valve, but then also some degeneration at the entire line of coaptation. Again, here there was some dilatation of the mitral valve annulus, preserved left ventricular function, a predominant mitral regurgitation jet at the center. So this is a patient with a mixed lesion with the main jet in the central part with a focal coaptation defect and then some degeneration across the entire line of coaptation. The dimensions of the valve together with the anatomy led us to come up with a plan to perform this as a single device implant. This procedure, as most of those, start with a transeptal puncture. The point you're aiming for within the septum is mid-fossa, so not too high, not too low, and if anything, that a little bit more posterior than anterior. If you're too anterior, then you make the procedure more difficult than needed. So before you perform a transeptal puncture, you measure the height, you aim for a distance to the mitral valve annulus of 4.5 to 4 centimeters. What you see here are the three components of the system. First, the guide catheter. Then the second component is the steerable catheter. The steerable catheter allows you to steer down to the mitral valve, and then by turning it, steering towards the anterior or posterior leaflet, and then at the end the implant catheter, which can be turned again, which enables one to get the clocking of the device right, and this will be shown in the case, and then the two steering knobs for the clasp, and at the end the actuation knob. So after the guide is placed into the left atrium, the device is then advanced through the sheath into the left atrium, and at this point in time the device is fully elongated and will then be closed. can see here that my surgical colleague is now turning the actuation knob at the end of the system, and thereby the system is closed within the right atrium, and that all under fluoroscopic and echocardiographic guidance. By closing the device is shorter, and thereby you can steer more safely through the left atrium down to the mitral valve. The steering down maneuver is achieved by introducing some flex on the steerable catheter. Now it is important to take some time to ensure that the system is truly aligned in a 90-degree fashion towards the mitral valve annulus in two planes, in the commissural plane and the long axis view. Once that is achieved, the device is then opened, again controlled under fluoroscopy and echocardiography, and as a next step, the clasp maneuver is performed to ensure which clasp is which. Remember, with that device, that device allows you for a staged leaflet grasping, meaning that the anterior clasp and the posterior clasps, they can be steered independently. What you can see here now on 3D echocardiography is the maneuver to get the clocking right. You always want to align the device orthogonally to the line of cooptation. So when you implant the device in the center of the valve in segment 2, then the device has to be orientated in a 6-12, in a 12 to 6 clock fashion. What we do now is we bring down one clasp after the other, and remember which one is the anterior and which one is the posterior. That was the anterior, and then as the second step, the posterior is brought down, and then we are ready to cross the valve. Now the crossing is performed as shown here, again on echocardiographic guidance. One checks on fluoroscopy to make sure that the clocking does not change too much, and also on echo, we can still see in the right panel on a long axis view that the device is slightly open, and we can see the two paddles. But sometimes when you cross the valve, the clocking can change slightly. So we go back to 3D to reassure, because this is very important when you want to achieve optimal results, that you have the device perfectly aligned, as said, orthogonally to the line of cooptation, and in that case 12 to 6 o'clock fashion. So the next step is carefully and slowly pulling back and bringing up the device, and thereby getting the leaflets on the device. You can see here now that the anterior leaflet is on the anterior paddle, and then the clasp is brought down. It is brought down now. The leaflet is captured. The clasp is still moving up and down. This is secondary to the motion of the leaflet. So this bouncing clasp sign is actually a good sign, because it indicates that you have a good chunk of leaflet captured. And then the device is moved towards the posterior leaflet by swinging it over and turning on the on the steering catheter. And then at the next step, on echocardiography, one assures that the entire length of the posterior leaflet is on the paddles, and the leaflet should actually touch the center of the device, which is called the apex. Once that is achieved, clasp is brought down as seen here. So in that case, we decided to do a staged grasping maneuver, anterior first, posterior second, and then the device is closed slowly by turning that one knob at the end of the implant catheter. And now it's time to wait and let the echocardiography assess what we have achieved. Now you can see that by closing the device, there was some tension on the leaflets, which again is a good sign. We see that we have some reduction in MR, but it might not yet be optimal. We checked for the gradient. Remember, the mitral valve opening area was 4 centimeters to start off, so not terribly large, but we have acceptable gradient. And then we check on 3D echo good orientation of the device, but still some mitral regurgitation, not terribly much, but we always aim for the best. And we see that we implanted it a little bit too medially. So we decided to reopen it and reposition it and place it a little bit more laterally. So what you can do with this device is to do multiple grasping, and this can be done safely, and we have no evidence so far that that cause any harm to the leaflet. And this is important because you have to optimize in cases and change the position and do maybe not one, but 2 or 3 graspings to achieve an optimal result. What we've done here, we moved a little bit more towards the center, so from medial to lateral. Again, we try to get the leaflets on. The anterior leaflet is on. The device is pulled back a little bit to have really good contact. Anterior clasp is brought down. We always use echo and fluoroscopy. Fluoroscopy helps. The main guidance is echo, but fluoroscopy can be helpful, especially to assure that the clocking remains stable when you get the leaflets on. Now the posterior leaflet was nicely on. Posterior clasp is brought down. And now again, the device is closed. You can see that that introduces some tension on the leaflet, which is a good sign because that's actually what you want to do. You can also see that this device is very flexible. It slightly opens and closes during the cardiac cycle. We release the tension on the system. And then another check on echocardiography. You can see here now that we actually placed it now really in the center of the defect. We have very residual mitral regurgitation. In this case, we check on 3D echocardiography that we implanted really orthogonally. And then on the right-hand side, you can see now a view from the left ventricle, and you can see that there's still a tiny bit of mitral regurgitation laterally of the device, but this is, if anything, mild. Now this is before release of the device. So the truth comes after you released it. Now the release involves turning the blue knob at the end of the system, as done here. The device is released now. This is quite a flexible system, and this, in our experience, allows to predict the result from pre-release to post-release with not a lot of change, and if anything, even better results after release. Gradient of 4, which is acceptable for above like that. And now the final result on echo Doppler. So even a further reduction, and this is what we would consider as mild, and we achieved what we wanted to and are happy with that result. Thank you.
Philip, I thought that was an elegant demonstration of the utility of this device in that disease. And it seems to me, because the attachment point between the delivery system and the PASCAL device is up in the atrium, that once you release it, you're essentially removing the stress from the delivery system on the device, and that it has a potential of improving the degree of mitral regurgitation. Has that been your experience, or can you share your thoughts about that?
Yes, absolutely. I mean, probably even more important, what our experience showed so far is that the result from pre-release to post-release in most cases is very similar. And as you mentioned, if anything, then even better. And this is important because when the device is still on the system, it might look better than that it seems, but with this device, you get what you see before release is what you get after release, and this is important for us to know when to release, and also to make a decision on when it's needed to optimize.
So in closing, I'd like to really congratulate my colleagues, Holger and Philip. I think they've really demonstrated the remarkable utility of this PASCAL device, its really unique features, and how it interacts by skilled operators to treat the mitral regurgitation. And we've got more data, more evidence that we really should be aiming for mild or no residual MR. I also think it's been interesting because this brings us to the next step with this device, which is its utility on the right side of the heart. I want to note that it just received CE mark approval for tricuspid valve repair. So on the right side of the heart, the PASCAL device has been used and just started in the United States with a randomized clinical trial. So we don't have a lot of experience here with it, but I think in the EU, Philipp, you have a greater experience with its utility on the right side. Do you want to share your thoughts about that?
I mean, the difference on the right side is, first, the leaflets are even more fragile. They're paper thin and see-through, so you need a system which is very gentle to the leaflets. And then secondly, the coaptation defects we are dealing with are normally much larger than what we see on the mitral side. So to have a flexible device, which is very safe and allows for staged grasping, to get one leaflet in first and the second in later, makes it an ideal device for the tricuspid valve. Tricuspid procedures are more challenging, especially the imaging, but our early impressions are very positive, and it's a perfectly well suited device for treatment of tricuspid regurgitation. Great.
And I think with that, we should wrap this session up. It's been an honor presenting this data and to working with my colleagues, Philipp and Holger.
Thank you very much, Scott. Thank you, Holger.
Thank you, Philipp. Thank you, Scott.